Welcome, everyone. We're just letting folks get started, and we'll just give it another minute or two. This is actually the inaugural policy program monthly webinar series at the Stanford Center for Biodesign. And if it sounds like I have to read that, I do, because it's a lot of words that I haven't normally read out loud in person. And my name is Kavita Patel. I'm the director of the policy program and could not be more thrilled to have this topic to be our inaugural webinar topic. We actually did host a webinar just recently on some of our work in the medical technology space. The reason I say this is an inaugural webinar is because it's a monthly tradition that we are going to start. And we're starting with this topic around artificial intelligence and going kind of what we hope is a little bit into the policy and regulatory space and beyond the hype, if you will. And so I'm going to, just because panel, I want to do moderator's prerogative. We have an incredible, I have to say that selfishly, it's always great when you can invite not just world-class perspectives on a topic, but when they're also incredible people to work with. And I can't say enough about the panelists that we have. I will briefly introduce them, but I think anybody who wants to, while we are speaking and they're speaking, can Google them, look them up. If you aren't familiar with them, you should be, because if I had to say anything around generally healthcare, as well as policy, as well as clinical innovation, these four individuals have literally been shaping it over the last several decades. That means collectively, the five of us have over 100 years of experience. And yes, that means that we're old, but some of us are older than others, and that's okay. So I will, but without further ado, I want to introduce Aneesh Chopra, who is not only someone who I had the pleasure of working with in the Obama administration, the first United States Chief Technology Officer, and not just the first, but someone who has continued throughout administrations to be an incredible kind of mentor to others, and he'll give us perspectives that I think are incredibly important on this topic of artificial intelligence. But I think Aneesh will also remind us how much of this is related to everything we talk about with digital health. And then Dr. Jerome Adams, the former Surgeon General, I should know the number, but in my mind was one of the most valuable voices, not just during the start of COVID, through COVID, continues to be an advocate for healthcare, trained as an anesthesiologist, is, I think, someone who has a very deft hand on lots of, hopefully I got your specialty right, but he'll correct me if I didn't. And he's got a deft hand in both the policy space, but also with his background in government leadership, management, as well as research. And he's currently the executive director for health equity initiatives at Purdue University. And then rounding out our incredible Stanford participants, Rohini Kosoglu, she's a policy fellow at Stanford's Human-Centered Artificial Intelligence Center for Human-Centered Artificial Intelligence, as well as a former deputy assistant to President Joe Biden and former chief of staff to Kamala Harris when she was senator and domestic policy advisor to the vice president. She is also one of our faculty at the Center for Biodesign, and she's teaching on this topic of policy, as well as, finally, last but never least, is Dr. Oliver Aalami. He is a vascular surgeon, director of our digital health program at Stanford Center for Biodesign. He is going to take a bit of a special kind of time. We were really hoping that part of these policy webinars is to actually show kind of innovation in action, and Oliver is going to do just that. So I couldn't be more thrilled to have what I would say is an incredible lineup. So why don't I'm going to start by asking our incredible, and I want to thank Molly and Antier and an entire team at Biodesign, Awo Addo and others for putting together. If you think that I'm the one that actually knows how to do all of this and make it look seamless, you're wrong. But I wanted to thank them for putting this together and helping to make what I think will be a monthly tradition, a very rich one. All right, so I'm going to ask if we can get the slide and have our three first panelists pinned together. And this is what I'd like to call, so let's have Aneesh, Jerome, and Rohini. And if Jerome is still on, if folks can come on camera, great. We will forever be grateful. Wonderful. All right. And then I'm going to wait to see if all of us are here. This will take a second. So I'll tee up, Aneesh, for you the question just while we're getting people pinned and doing everything. Again, Aneesh, welcome. I would love to have you just give us a brief perspective on exactly this title, kind of going beyond the hype. You and Jerome and Rohini might touch in different ways on some of the actions that are happening literally in the government. As we are recording this webinar, we know there's an incredibly important meeting going on in the Senate, for example, with leaders in artificial intelligence more broadly. But we also know that we're expecting an executive order from the White House and that we should also be seeing more and more action. Tell us how to balance this role of kind of regulation and kind of the pace of the private sector. You also sit firsthand, not just as president of Care Journey, where you're really doing a lot of work around kind of data, stewardship, value-based care, but you also have a seat on some of these innovative companies that are trying to bring AI into clinical care and other aspects. Tell us, Aneesh,
Well,
give us
first of
some
all,
perspective.
let me thank you for hosting us, Kavita, and to say your timing couldn't have been better, as all eyes are in Washington right now for the closed door session on the promise and potential of generative AI and AI more broadly. So let me set the stage to get this kicked off. We have a bipartisan tradition that we've been focusing on ways to grow the American economy to be successful in the global context. We called it the Strategy for American Innovation in the Obama administration. The Trump administration picked the ball, had it within the Office of American Innovation, and the Biden team has picked it up and continued. The general framework is as follows. We invest in the building blocks of an innovation economy. We work to set rules of the road to make sure that this capability has the most economic good and the least public harm. And then we issue a call to action to make sure that we can apply these very powerful new technologies in areas of national priority. In the Obama administration, it was in healthcare quality and cost, education, and so forth. So to set the stage, we have this framework that everybody sort of agrees upon. And the challenge is in the detail. When do you Goldilocks the not too hot, not too cold on the pace of regulation to stymie or encourage innovation? We saw in the Clinton administration, there was sort of a very famous provision, Section 230, allowed social media companies basically a liability shield protection from any lawsuits if they were to kind of, depending on the content that would run through their networks, an issue that Dr. Adams had to deal with social media disinformation and others over the course of the pandemic. But 230 was maybe a not too cold in that analogy, in that it gave the shield. It expected the industry to self-organize on a sword to proactively solve problems, which I don't think the industry really met. So it was sort of a whiff on balancing freedom to innovate with some consumer protection. The not too hot, I think, would be more of a European problem. Europe is quick to regulate. They're the first to have a framework. They're going to actually have rules of the road. And in my candid opinion, I think they may have gone to the point where they've sort of convinced companies not to innovate in Europe because they'd rather go somewhere where there's a little bit more freedom, because we don't know a lot of the answers to the questions that they seek to regulate. What we're trying to land on is a Goldilocks in the middle. And to me, the formula is what the Biden administration is doing now. Secure industry commitments to protect against the big harms on trust and safety. Commitments like allowing these big frontier models to get access to open up access for third parties to validate that they're not, inappropriately kind of harming individuals or creating biases in the outputs. So that idea of getting industry commitments short of regulation, but still enforceable, while enabling and encouraging kind of the call to action. You saw the president said very emphatically, I want to constrain you, but I want you to put your best efforts to help with cancer moonshot. So it had all flavors of this. We're investing in R&D. We've got voluntary industry commitments for kind of trust and safety, and then a call to action to help apply these technologies in cancer moonshot.
That is great. I couldn't ask for a better way to think about balancing. And thank you for reminding not just the EU, but I forgot about Section 230. And that used to be, I think, for many of us, kind of, it's funny how some of these things that are old are actually still kind of not just posing regulatory challenges, but interesting dilemmas. All right, so we'll get into some of this. And I should say, if folks want to, they can ask questions. We're trying to make this a little bit of like, kind of diving into some of these policy issues, but I'll try to take questions if I can on the chat. And then go from there. All right, Dr. Adams, one of the things that you taught me when I first met you was really thinking through a concept that I think you're going to have some slides. So while we're speaking, if you want to go ahead and share the screen and take over for slides, feel free to do so. One of the concepts you've talked about passionately and have taught me a lot about is around digital disparity issues. In fact, thinking about a digital divide and and I think there have been thoughtful pieces written about some caveats and potentially unintended consequences, particularly around artificial intelligence. But you've kind of talked about the power to do better, to actually kind of decrease disparities, and as well as this peril of enhancing disparities. We have a number of very prominent researchers and interested kind of academic as well as innovators at Stanford. What do you think, Jerome, having this audience of innovators, educators, and researchers, what should we be concentrating on?
Well, thank you so much for having me today. I just want to verify you can hear me and you can see my screen.
Yeah. Yes.
Okay. I'm at Purdue now, and Purdue is known for Neil Armstrong, for putting the first man on the moon. We are known as digital and tech innovators. And I'm a physician, and I'm a physician who needs to get my teenagers to actually help me update my smartphone and install stuff on my computer. So I know nothing about digital health and technology at kind of the ground level. But I do see a tremendous opportunity to merge the spaces I've been working in, which include health equity. I'm the director of health equity with this new world of AI and digital health. And I've really talked about this idea of digital health equity, which I think it's important for us to focus on and to think about as we move forward. So I'm going to walk you through a couple of slides really quickly so you understand how I think about this issue, starting with this famous quote from MLK: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Well, I think it's important for us to understand that MLK's quote was fantastic, but it was incomplete, because we know equality is not the same as equity. Different people need different things in order to be successful and to have these same opportunities to achieve optimal health. We also know that we spend about 90 cents on every dollar in the United States on traditional healthcare or medical services, but we still get terrible results because healthcare is not health. We know that health behaviors, social and economic factors, and physical environment all play a role in your ability to be healthy, more so than your access actually to a traditional doctor's office or hospital. So what is health equity? Well, it's when everyone has a fair opportunity to make healthy choices and can be the healthiest and happiest version of themselves. And when I think about health equity, I think about the fact that I live in a high opportunity neighborhood. I've got broadband. I've got a big house. During COVID, when we asked everyone to stay at home and do virtual schooling, my kids each had their own room. Had good access to Wi-Fi. It was quiet. They wanted to go outside and take a break. They could, because big open spaces, complete streets, sidewalks, etc. We were in a high opportunity neighborhood, but far too many people live in low opportunity neighborhoods where they don't have access to appropriate transportation, where they don't have quality schools, where they don't have healthy living conditions, and so on and so forth. So how can digital health impact health outcomes in a positive way? Well, a lot of the focus so far has been on electronic medical records, looking for individual or population level patterns, pinging the MD or care provider, making sure you're following the appropriate protocols and algorithms. Wireless medical devices and wearable technology. So Ezekiel Emanuel and I were just on a CDC webinar last week talking about hypertension control and the promise of using wearable blood pressure cuffs so that people can take their blood pressure at home, avoid white coat hypertension, get that transmitted to their care providers, and get immediate feedback as to whether or not they need to adjust their medications. Text message reminders and interactive health technologies equal increased engagement and compliance. As any of you know, if you've gotten a text from CVS or Walgreens to make your appointment for your COVID vaccine, in the next week. Telehealth equals increased access. Virtual and augmented reality as a therapeutic or educational tool can be an adjunct for physicians. So think about smart glasses and the ways we're thinking about using those. And this leads into gamification. We've seen that can influence health behaviors. And just to make you think about that really quickly, think about the Wii and how people were using that as a way to encourage physical activity in folks. Smart homes or smart environments can really help us understand air quality, can help us understand if there are triggers in our homes. Think about if you had that for asthmatics to help them understand, hey, it's a bad time for you to go outside, stay inside today, particularly with the recent wildfires that we've had. Cybersecurity remains a barrier to people's willingness to embrace digital health, and we need to really think about that. I was surprised how much of my time as Surgeon General was taken up addressing cybersecurity threats to the medical industry and beyond. But despite all the promises, here's where I want to finish. I want us to be aware of equity and ethics concerns. So there's a digital divide by geography. Rural communities don't have broadband access the way urban communities do. By education, by age, we know older people can't access technology the same way younger people do. By economics, can you afford a computer? Can you afford a blood pressure cuff? By home environment, when we looked at virtual schooling, we knew that we found one of the big problems was you needed privacy. If you lived in a room with your brother and your sister, because that was all your parents could afford, how are you going to do virtual schooling with 3 people in the same room at the same time? And there are trust deficits in many communities, rightly so. Who has my data and what will they be doing with it? So think about Henrietta Lacks and that famous case of using her actual tissue. Well, now we can use your data in ways that help other people, but may not help you. Bias, as Aneesh talked about, AI algorithms are subject to the garbage in equals garbage out phenomenon, and bias that's baked in can never be fully corrected for and often gets amplified. How's the information being used? Are you subjecting people to the discrimination on their job site for insurance coverage? Think about even sports. Sports teams would love to be able to know who's at higher risk for injury or not when they're going to decide whether or not to give someone a new contract. I mentioned who's profiting Henrietta Lacks. Is information being given back to the patient? In many cases, we take this information and then we charge the patient to get their own information back. How ridiculous and unfair is that? And the ethical question, just because you should or could doesn't mean you should. Think about cloning, thinking about picking the characteristics of your child. Think about the question, the age-old question from movies. If you could know when you were going to die, would you want to know? Well, now we're close to actually being able to help people understand that. And whose job is it to police this? So my assertion is that we need diversity at the table from the start to see past our blind spots. Some famous examples, we knew that during the pandemic, telehealth increased by over 7,000%. Great if you're increasing access to marginalized communities, but guess what? Growth of telehealth occurred mostly in affluent and metropolitan areas. So we actually increased disparities with this new technology. I have asthma, and we know famously, we've recently discovered and acknowledged that when it comes to pulse oximeters, they weren't set up as electronic devices to perform the same in people with darker skin as they do in the people who they were mostly tested on, people with lighter skin, causing mis and underdiagnosis in people from Black and brown communities. And perhaps you saw this earlier this summer, Black men were underdiagnosed with lung problems because of bias in the software that the machines were using. These are all examples of digital health inequities. So digital health equity, to me, is an important part of creating high opportunity neighborhoods for everybody so that we can all benefit from this new era and we can all realize the full promise that is before us. I'm going to stop sharing my screen now, and screen sharing has stopped. Great. And I'll say that I'm just looking forward to this conversation. And I really am excited about the promise of digital health, but we have to make sure we're thinking about the unintended consequences and that we aren't creating a greater health divide by providing the haves more resources and denying the have-nots that same opportunity to avail themselves of these new technologies.
Absolutely. Thank you. That was and I think we can all agree that a lot of what you're discussing, again, if I could have just kind of taken out the words digital health. We could insert some other words that have come up several decades ago, even like electronic health records, for example, or kind of interoperability or data sharing. And so a number of these concepts wrap into some of the same themes that we unfortunately have a lot of promise and have a lot of kind of unintended consequences.
We've been here before.
We've been here before, so we should know and we should learn. But I often say that, haven't we learned or heard this before? But we have a chance, and I look forward to a group like this kind of working on solutions, because it does take policymakers, clinicians, patients, voices, takes everyone to kind of really think about it. And that brings me to Rohini. Rohini, you have been one of literally, as the Hamilton song says, like in the room where it happens, kind of firsthand witness to what I would argue are some of the most incredible milestones in health policy, certainly Affordable Care Act, Cures 2.0, CHIPS, Inflation Reduction Act, which had some incredibly prominent healthcare provisions. And you've also been now kind of in your post-government career, very active in thought leadership with respect to artificial intelligence and just general health policy, tech, and kind of economic policy issues. So tell us, you've talked about, I've heard you speak about this, but I want to have you just get a chance to kind of level set a little bit. I think we'll have a lot of people who are actually probably a lot more like Jerome, who are going to say, look, I'm not the technical expert on digital health, artificial intelligence, but I now need to be the person that's leading some of these efforts. I need to be a decision maker and try to do some of this. So tell us where the compass is pointing and kind of your perspective of where we are right now in this moment in time. And we'll just, you go off mute.
Yes,
there you go.
Well, you're exactly right. We are at this really critical moment in time. It's not every day on an issue that Congress is working in a bipartisan way. They're working with the administration. People are information sharing in ways that is not often seen in Washington. But another factor to layer into it is how much, this issue of artificial intelligence can seem really intimidating to so many people. We talk about foundational models, large language models, and these are things that people wonder, like, am I missing the boat? This seems, this is for tech policy people, but more and more, as you can see from all the things people have said, and what is really on the top mind of policymakers, their staffs, all of, as people are thinking about it, but just even everyday Americans, it is going to affect every different sector of society. And so the critical need for voices in this moment is so important. And so, you have people that have been decades in, health policy here today, other sectors. You will want to know if you're sitting with that doctor, what kind of software they use to if that help with your diagnosis. You will also want to know if you don't have enough data on a condition that you have, what options are available to you in terms of how artificial intelligence can be used to help develop some treatments for you. So these are often things that people are, in the health space can be excited about. But I think to Jerome's point, there's a lot of work to be done in terms of bringing everyone from different coalitions and where they've been experts in their own space to be a part of this conversation. And so one of the things that, as Aneesh talked about earlier, it's evaluation of these models. Right now, we're in such a nascent stage where people don't actually really have a good, credible sense of, does this model do what it says it's going to do? Does it meet the standards that different governments across the world are putting out? We at Stanford have looked at this and found that it's very weak when it comes to evaluation of the current models that are out there. Another aspect that people should be concerned about, I think, is the dynamic we have in the healthcare world when it comes to breakthrough discoveries. A lot of them come from NIH and through the work of academic centers. And in the world of artificial intelligence, what we've seen in terms of most of the models have been in the private sector space, largely because access to what they call compute, which are essentially powered by the chips, the semiconductor chips that everyone reads and hears about with NVIDIA and others. Getting access to that is really expensive. And so most of it are going to people that have the capital to invest in those kind of technologies to create these models. And so making sure that there's more democratize access to get the access that they need to this computing power in order to create models of their own and analyze data, something that's going to be really important as we move forward. And so I really encourage everyone to keep staying engaged and keep using their voice, because this is something that's not going to be a conversation for just it should not be a conversation for just the tech experts of many, many years.
No knock to the tech experts, but
Yes, exactly.
I agree. We love our tech experts. So let's bring. Thank you, Rohini, and I want to. If it always seems like we're always so pleasant when we work, we actually are, because that's how things get done. And I think the four of us can safely say that we've had to work on really difficult kind of economic issues, policy issues, healthcare issues. Certainly, COVID forced function a lot of that, and it's really by kind of putting this all at the table. And I will say it's very important that, Rohini, I want to kind of boldface, underline, underscore, kind of bringing perspective. Something that we always try to do is making sure that we really do understand. We talk about the patient like this ephemeral kind of entity that's like over here. I think first of all of us attending the webinar, we're all patients. And then second of all, we probably don't do enough of trying to understand, exactly to your point, and Jerome and Aneesh, all of us trying to understand kind of how people see the value or don't see the value of the data. I think, Aneesh, maybe we can start with you and we're going to do some different questions for each panelist to kind of really expand on these kind of thought ideas. But let's talk about, you have really been part of, you can talk about kind of data stewardship, interoperability, the Blue Button Initiative, which expands for all Medicare beneficiaries to be able to see all of their information literally with kind of one access point, kind of, since we have that luxury with Medicare claims data and understanding the trajectory, and then trying to get that even obviously beyond a Medicare population to everybody. Aneesh, when you think about kind of the work that is still going on in this area, and we've made meaningful impact, and then you look at this open kind of field, which, by the way, I should say, artificial intelligence has been around for decades. It's not that this is new, but there has been this inflection point. Aneesh, can you talk about like some of, you were also in the room where it happens, if you were giving the president advice or trying to take that executive order and push a little further and thinking about our lessons that we're still learning on data and interoperability, what are some important kind of policy areas, guidance, caveats that you would give the president?
Yeah, so I would start with a first principle, which is bedrock of HIPAA, is that the consumer has the right to access their health information. And that bedrock right was not technically defined. It was kind of functionally outlined, but we don't have the standards in place and deployments live to make that a reality in today's connected smartphone world. So what we worked on, and I think an area that the president could weigh in right now, is to extend the same benefits we offered with Blue Button, and then in the Trump administration, Blue Button 2.0, to allow application access to your health information, to connect it, as President Obama said, to the applications and services that can help you make sense of it. Now let's peel this onion back for a moment and explain why this is like job one. Me as a working professional within I have an insurance company, Care First is our back end. I can't get my health information from Care First in the way that my mom and dad can on Medicare. Why? Because they're not subject to the CMS interoperability rule, only government-sponsored plans. Commercial plans are not. In California, where we're recording this webinar for you, the state of California did, in fact, impose these requirements by 1/1/24 on all employers. So thank you, California. You're going to lead the way. But what about the 49 other states? And so we do have to finish the job of taking the spirit of consumer application access rights now that we have the technical standards. And the irony of this, Kavita, is insurance companies have to actively say, I'm going to convert only a portion of my data into the FHIR format and not do it with this other population, rather than just say, hey, you know what? Even though the government said this for just a small population, let's do it for everybody. Pathetic. That just tells you a little bit of the priorities of where consumerism fits. The second principle is that from a regulatory standpoint, what I choose to do with my data is my choice. There's more freedom, depending on how you sit on the political spectrum, which also means the risk of harm if I interact with someone that deceives me? So I co-chair the Karen Alliance with Governor Levitt, bipartisan, and we put in place a code of conduct that went beyond HIPAA to make sure that the applications that are trying to compete to help people make sense of their blue button data can do so at a higher bar. And the big one there relating to AI, today, nothing stops Stanford, the medical center, from selling all of your medical records to app developers and AI builders, because de-identified data is not subject to HIPAA review. So as we speak right now, billions of medical records are sold to AI developers without any oversight and without any agency for us. So in the Karen Alliance, we said at a minimum, if you intend to interact with my medical records as part of an AI process or any kind of de-identified use case, it must be disclosed. We don't say in the Karen Alliance that you can't do it. We just have to disclose it. I would like to know that this is the business model of the organization that I'm working with. So that step 2 is we need rules of the road that protect against these consumer apps that kind of go beyond currently what's regulated in HIPAA. And I think the work we've done on the Karen Alliance is a step in the right direction. And then last but certainly not least, and I think this is where you saw Peter Lee, whom I love and many of us know and respect, was at DARPA in the Obama administration, now is Microsoft's lead for a lot of healthcare-oriented research. He took his lab results, personal lab results, put it into GPT-4 and said, anything here I got to worry about? And it went through his information. He published his results and it said, you might have some form of anemia. You might want to look into this, this, and this and ask your doctor about. I think if we get more and more of the systems to think about decision support that takes the U.S. Preventative Services Task Force recommendations and any other preventive services care gaps and other things, the good stuff that many of our academic and research friends have said for years, why wait 17 years bench to bedside? What if we could sort of actively issue a call to action to bring that information into the forefront so that when I organize my information, I get access to that level of insight? We haven't had that yet. So that's the call to action. I think many of the folks listening today in the biodesign program, they might be the ones to build said decision support. So that's why I'm bullish, but to frame the power of consumerism, maybe the tip of the spear on the go forward basis while we lock down some of the inappropriate uses in the more traditional business to business use cases.
I love it. And I love that you're pointing out something that I often, when worked in health systems, if it's, HIPAA did a lot of things and we can talk about it, but it's a very clear that if it's de-identified, it's also kind of an open forum and an important one. I mean, you and I can talk about some of the incredible applications of said data that have led to better intentional information about managing populations, giving me as a clinician better information. So thank you, Aneesh. Jerome, there's some good active responses in the Q&A. I told you this is a panel that is not just world class, but they are very responsive. So go ahead and ask more questions. Jerome, I'm going to kind of ask then for you that if we do kind of accept that, as we've described, that AI, in my opinion, is like the internet. It's a commodity. It's not this magic solution. It's this thing that we can do important things with or not and leave others behind. Aneesh has already pointed out about much of the work that still has to happen around data sharing. So if we take that theme a little further and kind of, go and push, you put in your slides, I think eloquently, some very key areas where we still have a lot we could build. I'm going to ask you, because you had to do this as Surgeon General, you can't do everything. So what would be kind of the first area that you would actually say in healthcare, in a use case, whether it's in the public or private sector, deserves more attention?
That is a great question. And I'd say there's a couple of areas that we're already working in. So I'm actually the board chair of an organization called the Association of Diversity in Clinical Research. And one of the things that we've seen the FDA and also CMS do is use their authority to actually promote increased diversity in clinical trials by making companies submit a diversity plan and by making it easier for people to participate in clinical trials. So there are levers that we have at the federal level to do this. Well, when we're thinking about digital health moving forward, we need to think about the levers, because a lot of the money is going to come from the federal government. And that lever is to say, hey, we're going to establish standards that you have to abide by before we fund your product. Now, you mentioned this earlier, Kavita. This isn't, we've been here before. This isn't our first rodeo. And I talk with Francis Collins, the former NIH director, about this frequently, that in many cases, we push for the innovation without a thought to the ethics, the access, or the equity. And then we wait for problems to emerge, and then we try to deal with those problems on the back end. What we really need to do is think about these issues upfront and fund research in the space of digital health equity and inequities upfront, so that as we're designing these new systems, these new products, it's baked in. Because to your point, when it becomes a commodity, at that point, it's really hard to then force change into the system. I don't want to say that it's a bad thing. I agree with you. It should become available to all people, because commoditization increases competition. And another peripherally related activity that I dealt a lot with when I was Surgeon General, because we were involved with the opioid epidemic, we were trying to increase integration of prescription drug monitoring programs into EMRs. And I'm not going to call out the particular EMR because I know you all know it, but they were charging $250 million to companies to actually integrate their PDMPs into EHRs. And so big health systems could actually pay this money, but smaller hospitals couldn't pay this money, and so they didn't have access to the PDMP data, and you saw that disparities were increasing in those communities, which were largely rural or more underserved. We need to think about these issues up front. We need to hold companies accountable, and we need to promote competition so that we don't end up with a with one player in the market, but we also don't end up with a lowest price, but also least flexible and accountable solution to our difficult problems.
I love it. I think Aneesh has some rapid. Aneesh, did you want to just briefly respond?
Dr. Adams hit something that frustrates me to no end. States purchase that one system, and they fail to mandate that they use FHIR open data standards to make it available. This is entirely on state governments for failure to put this in the contract when they pick the one vendor to rule them all. And it's annoying because Dr. Adams is spot on. Dead weight loss, frustrating. It shouldn't be, but that's on us. We got to fix it. And so I sure hope someone on this line is paying attention for state governments. Those who issue monopoly rights to PDMP data have to make that open by default. And we've been trying for a decade. I can't get a single state to commit to this.
I love it. And we will get response because that's exactly what this kind of a forum is intended to do. Great. Perfect. Well, let's shift to, we've had some questions. Rohini, I failed to mention in your bio that you're a venture partner at Fusion Fund. So when we talk about this kind of harnessing of investments in the private sector, as well as the public sector, you're living it, you're breathing it. So I'd love to maybe just have you think a bit more provocatively. Where should we kind of expand more economic incentives, whether they be use cases or certain parts of the healthcare sector? And what should that be, as well as where should we be pushing? I think everybody involved in venture capital, private equity, or private investments sees a flurry of activity in artificial intelligence. Where can we have better investments? And I'll just kind of say, it's not always in that kind of clinical decision making, or what I would say is that consumer use, kind of the chat GPT, if you will. There can be some other really important back kind of very clunky administrative functions that are wasteful kind of sources right now, cost centers, if you will, and that could be an opportunity. But Rohini, please expand what you would do with the economic.
I think so. That's exactly where I was going to go to. I mean, I think, when I've been on the other side of, how do you design laws, and a bunch of us have, how do you design laws to incentivize the right behavior? It does start with, I think, the business community, people all over the private sector being more honest about what things they're going to invest in to make them more money. So if you're talking to most venture capital investors in terms of where capital is going to be allocated, right now they really are asking the hard questions about, like, where am I going to get my return on investment if you do X? That doesn't always align with what the consumer wants, what the patient wants. And so you could definitely see a scenario where we live in a space where the main things that happen don't necessarily do things to advance on behalf of patients, and that they're sort of a byproduct of company moving forward, pitching to enterprise, pitching to different medical centers, but it may not, you know, at the end of the day, whether it's, you know, venture or hedge funds, private equity, big healthcare systems, they're all thinking about, well, how is this going to affect our bottom line? And, you know, often they're reticent to share that with policymakers, whether they're at the state or federal level, like, this is what we're thinking through in terms of our bottom line. And so it is a lot harder to have those conversations when you're really trying to get to the heart of, okay, what's the right regulation or the right law to incentivize that kind of behavior? I think that a big parallel that the healthcare sector has seen that the rest of the tech world hasn't lived through was certainly around electronic health records. So the promise that we all had that this was all going to be interoperable and we were all going to have everything at the fingertip of all our data at our fingertips, and it was all going to speak across all the healthcare systems. I think we've discussed the different barriers in place, but the healthcare sector has actually seen this sort of big promise and then not the same results. Whereas the tech community, I think, is a lot more optimistic that everything will be solved by various certain aspects of technology. And so it'll be interesting to watch sort of as we go down this process, because I actually think healthcare people have a lot to offer the conversation about, well, you know, you might think it will look like this, but we have seen this before and it hasn't necessarily turned out in terms of how the incentives were aligned and what information was open at the beginning for when you're having these conversations.
Well said. All right, we're going to jump into a little bit. I'm going to let the current panelists recede, and if they need to go off camera, get a breath of air, water. I encourage everyone to look beyond your monitors outside. It helps your eyes for every 20 minutes. I'm going to let them do that, and I'm going to make sure now we want to talk a lot. I think we're going to see, and I'll invite Oliver to the main stage, if you will, Dr. Aalami, who's been not only a leader at Stanford and nationally as well as internationally with biodesign, digital health. And what I would say I love about Oliver, it's very rare that an internist like me meets a vascular surgeon who is more emotionally grounded than any surgeon I've ever met. But he is someone who has really like walked the walk with thinking about expanding the use of this impressive technology vis-a-vis artificial intelligence, large language models to populations, and actually doing this with a very core skunkworks team of incredible people, small but mighty. And I would want to invite Oliver to give this. Some people have asked about practical questions and expense, and I think, Oliver, you can feel free. I think you have some slides you want to present. Feel free to share the screen, but let you talk about what your work encompasses and how this is meeting the needs of some of what we've already heard. So please go ahead.
Perfect. First of all, you guys can see my screen. Just want to make sure.
Yes. We're
all
good.
right, fantastic. Thank you so much for the opportunity to participate. I'm really honored to be among such esteemed panelists. So I am a vascular surgeon, but at the same time, you know, having grown up here in the Bay Area, very much, you know, was very into digital health and so on, and especially excited about the potential. Jerome talked about the potential of digital health and how can we squeeze the most juice out of the potential. And so I am, you know, being part of Biodesign, we're very, 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 very interested in translation of these concepts, ideas, you know, from research into practice. So, and when you think about the framework that Biodesign uses, we really try to look at all the stakeholders. And what digital health brought, which is really interesting, and this was an insight from Paul Yock, one of the founders, was that digital health really brings the patient in as a real potential stakeholder, especially now that we have digital, with all this technology with connected devices and such. So I think that's a really important starting point. And there are also, Aneesh brought this up, and Rohini has also brought this up. There have been tremendous regulatory updates. You know, we should have significant tailwinds, you would think, with all the mandates and such for data interoperability and data being available. The 21st Century Cures Act final rule, especially, you know, preventing information blocking, picking the FHIR standard as the standard, and it's been brought up a few times already. And the fact that, you know, this date already passed, it was the end of last year, December of last year, all EHRs that or from hospitals that receive Medicare payment needed to expose a FHIR API. And that's a big deal. And here's the timeline for all these the final rules. And by the end of this year, even more electronic health data is supposed to be exposed by hospitals and such through these FHIR APIs. But clearly, as we've heard, we've had quite a few challenges with enforcement. This is just a fun little, I guess, X now, formerly Twitter, by Mickey, talking about how excited he was about all these, about the potential of this data starting to flow. TEFCA is another thing we hadn't talked about yet today, but this is an attempt at policy to it's the evolution of health information exchanges, where they kind of define the business rules around how data should be exchanged and such. It was supposed to be FHIR based, but that's being challenged currently, and that's a hot topic that we may talk about in terms of how policy can help prevent kind of escape routes for health systems and such to avoid sticking to interoperability standards. But all these rules and such, led to things such as the Apple Health Record app, which is pretty amazing to be able to get your health record on your phone if you have a health system that has exposed this. We heard about Blue Button. You can now, as a patient, you can access your claims data, which is pretty powerful. Android has an equivalent FHIR API called Common Health that you can develop. But really, at a high level, this is where I get excited, and this is what when I teach in the classes that we have here, is that we were supposed to be moving or enabling a consumer or patient authorized data exchange, which is what all the panelists have already discussed. And this is supposed to be, it should lead to empowering the patients more, giving them, letting them be the stewards, and also having more transparency about what's happening with their records. There's this whole concept of consumerism in healthcare is even being picked up by all the big box companies, whether Amazon, Walmart, and such. So what we do here, we're really focused on translation. So we teach around this. We actually provide tools, and this is what Kavita was referencing. We have something called SPESI, an open source framework that I'll get into a little bit, and we do a lot of research in this space as well to see, what are the possibilities currently given the opportunities. So really, we take projects from the hospital and have students build out solutions for real world solutions for the hospital and the clinic. And to help do this, we've created this open source framework that really leans heavily on these HL7 FHIR resources that are available. And we're basically FHIR native out of the box with this framework. We work closely with university IT and such, and kind of have a template application. This is how we started. We had a template application you could work with to build these solutions, and now have moved to also providing tools to make it very easy to build surveys. A web-based FHIR survey builder, for example, as another tool. We try to make it really easy to connect everything to the cloud. So for us currently, we use the FHIR or the Firebase cloud storage from Google. And again, we try to keep everything FHIR native. We have a Smart on FHIR dashboard so that it can be deeply integrated into the EHR. And I heard from Jerome earlier about the blood pressure monitoring use case, and we have actually something where we're monitoring blood pressures remotely. It comes into the electronic health record. The physician gets an inbox message, and with one click, there's a recommendation. With one click, they can order that medication change for that patient to kind of help streamline the process. And again, this is all open source. This is all meant to be available and to be built and expanded on. And some examples that we've been working on, one is a remote Parkinson's monitoring system called QDG. There's a remote patch testing. Getting access to specialists is incredibly hard. And so we helped a dermatologist develop a remote patch testing kind of system, end-to-end system. We also help researchers study green spaces. You know, how does the environment where you live affect your outcomes? This is that's super important. We have a remote therapy for cerebral palsy application that we've built. Pediatric Apple Watch study. How does the Apple Watch do on kids? You know, we have a congenital cardiac program at the Children's Hospital here, and they get a lot of parents who come in with arrhythmias that the kids are having that were detected on the Apple Watches of the parents. So can we validate that? We have working with psychiatrists around anorexia nervosa and other mental health issues. And then I guess that with all the hype, you know, this was talked about earlier with AI, you know, how can we leverage all the latest? We've done some research to see, can we interact with our health data using these large language models? So we built some open source demo apps that are available to download, so you can interact with your health data, whether it's, you know, the step counts or even your health records potentially. And this is the one where we're taking the FHIR resources that are available and we let you interact with those FHIR resources. And it's pretty powerful. These are just demos and, you know, just to show what the potential is, but it's incredible. What I'm actually most excited about, and this came up, and I think, Jerome, this really speaks to the work you do, is that, you know, can we use these LLMs to really help more people understand their health information, translate the information to whatever language you ask it a question in? Can it respond in that language? So there are a lot of basic things we can do. And there's another demo that we built that's also available and open source, where you can interact with your health data and just make it more understandable, accessible, and such. So the last thing that I'll talk about is that, you know, privacy. Every time we release these demos, the biggest concern was always privacy. You know, are you crazy? I'm not going to release my health records or give my health records to LLM. And we agree that this is an issue and is one of the things, you know, transparency around how the data is being managed is critical when it comes to, you know, regulation potentially around these things. And so we're doing some research around what's called fog computing. Instead of sending the data to the cloud, can we process it locally somehow more securely? So I'll stop there. I hope I didn't take too much time, and happy to join discussions, answer any questions. But that's in a very quick way, a summary of the work, some of the work that we're doing here.
You know what I love, Oliver, is you make it just seem so easy. He's just going through these slides. He's like, oh yeah, you know, we did this, national this. I think it's incredible. And it just, I have to say, it's one of the reasons Stanford is just an incredible place. All right, because people don't think policymakers and nerdy policy folks like us like to have fun, we're going to end with some very practical tips, and bring all our panelists back. This is closing it out. We know there's a lot of valuable questions. We've already been talking about ways where we can incorporate some of the answers. So expect to see more from a substantive crew like this one. We also, I just have to put a plug in, started a new policy fellowship in the Bayer Center for Biodesign. Our fellows who are watching this are 6 weeks old, 7 weeks old, and some of our esteemed panelists here are going to be their faculty, including Oliver leading the digital health. But I'm going to end with something fun. It's a lightning round question. Most kind of fun and favorite use of AI. It could be your best use of ChatGPT-4. I'm going to give you mine. I have been using it to plan my kids' like weekend activity itineraries, and it has been genius because I feel like I'm a traffic air control cop when it comes to trying to see like what's available, what's here, what's there. And I've been able to get kind of a nice little customized use of things to do for my children in the area, along with their age groups and whatnot, and a lot of interesting commentary. Oh, and then a little tidbit before I give talks, I don't give as many as I used to. I actually asked ChatGPT about my record of what I've said in the public domain on a certain topic. And I'm sure some of us can relate. I'm like, did I really say that? Okay, great. So those are mine too. I'm going to go in the order I have, folks. Rohini, best fun use.
Okay, I definitely have used it when I am making travel plans, because I find myself having very specific things I am seeking that I may not want to share with a person. And because I'll just use this example because we're all friends here. So you know, if I'm going with my husband on a trip, I really want to find an adults only place where I'm not going to see a bunch of children. I love my children, but I just don't want to, you know, necessarily see other people's children at the same time. And so, so I will seek out those kind of things, and I won't feel like I have to explain myself to the large language model. And I will explain various things that I would prefer in terms of restaurants and things like that. So I have been, when I'm trying to decide.
I have to say, there are so many things that we could say on that, but I got to give a shout out to Rohini, because she is one of the people, if any of you are parents who have noticed the prominence of having a space, this dedicated space for nursing, and having that space dedicated for breastfeeding, for nursing, public spaces, private spaces, employers of a certain size, you can thank Rohini for that. She's the one that made sure that that got in the Affordable Care Act. So she's always one of my favorite people, because just in case you think she wants space without her kids, she has made space for all the children, for the moms and dads in the United States. All right, Aneesh, favorite use.
Yeah, same theme. Taking my wife to Europe, and we're doing a conference, and I said, find me an itinerary that would allow me to kind of put in the parameters about where I wanted to do and how I wanted to handle it, so I could have a few days extra. So I think travel is the winning theme for personal use. It's delightful, actually.
I love it. I love it. Jerome, something fun. And I know, because I know your kids. I know you're doing it.
Mine is not travel, and it may not be fun, but it's been incredibly helpful for me. This, I have to give Scott Gottlieb credit for this. I still do a lot of TV interviews, and when I'm asked a question on a particularly nuanced or hot topic, I'll ask ChatGPT, what they think. So this morning, ChatGPT, what should I tell the American people about phenylephrine containing compounds? Because I did an interview this morning, and I've got another one coming up this evening on that topic. But another kind of fun one, I hate doing graduation speeches, because everyone wants you to be brilliant, but they also don't care that you're there, because they're not actually there to see you. And so I've used ChatGPT to kind of help me develop the outlines for really impactful but brief speeches I can give at graduations that I can then edit. And so in that way, I guess I'm using it a lot like my kids are. But it's been incredibly helpful for me in both of those two areas in my life, and made things a lot more enjoyable to me that I previously have seen as just kind of, oh, okay, I got to do this interview. Oh, I got to do this graduation speech.
I'm going to steal that. I have to be honest, I'm friends with Scott. I don't think I've thought about using it to do that, but it's a brilliant one. I love it. Okay, Oliver, fun use.
So, gosh, I don't know if this is fun, but it does involve a little bit of creativity. So, we're creating all these products and apps and so on, and you have to name them. You have to come up with clever names, and believe it or not, it's I feel like ChatGPT does a pretty good job in being creative and coming up with acronyms or fun names. So if anything, it's a great way to bounce ideas off. We had this one project we're doing where we're trying to, and then we had such a long scientific title to this grant application where we're using EEG devices to diagnose autism in kids. Mm-hmm. And we kind of could not come up with a name, and we asked it, and it came up with Neural Nest or Neuronest. And I thought that was kind of a good idea if you have a little EEG device. So
it is. I love it.
That's kind of the use case that I've
here. I'm going to use all of these use cases. This is excellent. I told you I'd end on time. I wanted to make sure I am giving everyone a virtual and physical round of applause, because truly you couldn't make someone like me, who doesn't necessarily always kind of wake up and think about digital technology, feel not only like we have a lot of work we can do, but it's important work and enthusiastic work with people and partners like you, and we can have fun doing it and go someplace we can travel on it too. So I love it. So thank you, everyone. I want to thank all the attendees, and we'll make sure that we keep everyone who wants to take an active be on our mailing list. Anybody who's interested on it, we'll send a kind of post-webinar survey to those who attended, and you can get on our mailing list. But take care, everyone, stay healthy, and COVID vaccines are available. Some have said that New York City has them as soon as today.
And your flu shots, you can get both at the same time.
Thank you. And your RSV shot if you're over 60, and a number of other immunizations people should catch up on. You can get them all at the same time. All right, take care, everyone.
Thank you.
Thank you.
Bye-bye. Thank you.